Thank you for the opportunity to discuss risk stratification and management of dysplastic Barrett's esophagus. The current management of dysplastic Barrett's esophagus includes, for high-grade dysplasia, expert pathology confirmation, EMR for lesions, and ablation of flat mucosa until complete eradication is achieved. For low-grade dysplasia, surveillance EGD with high-definition white light endoscopy within 3 to 6 months to rule out a lesion and perform EMR if present, or ablation if low-grade dysplasia is confirmed and persistent. Clearly, not all patients with Barrett's esophagus without dysplasia, indefinite for dysplasia, or low-grade dysplasia progress. So how can we do better in selecting patients for endoscopic eradication therapy or routine surveillance? Risk stratification is defined as the process of assigning a patient to a particular risk status to help make management care decisions. This includes present need for treatment, and the question of whether neoplasia is present now can lead to the decision about performing endoscopic eradication therapy, surveillance, or if there's no Barrett's, no surveillance. It also includes the process of quantifying the probability of a harmful effect, like cancer, to individuals resulting from internal and external factors. This includes future risk and prevention, and therefore the question of will cancer develop can also impact on decision-making regarding endoscopic therapy or surveillance. Now, why is risk stratification in dysplastic Barrett's esophagus so important? The natural history of dysplastic Barrett's esophagus is variable. Pathology, which is our best biomarker for cancer in Barrett's, is subject to variability, particularly for indefinite or low-grade dysplasia. Dysplastic Barrett's provides an opportunity to perform endoscopic intervention to prevent esophageal cancer. Therefore, we do need improved patient selection because the minority of Barrett's patients do not progress to cancer. The natural history of Barrett's with low-grade dysplasia is illustrated in this very elegant SURF trial, which was conducted from 2007 to 2013. In this trial from the AMC group in the Netherlands, randomized 136 patients to radiofrequency ablation versus surveillance if Barrett's esophagus low-grade dysplasia was confirmed. The outcome of radiofrequency ablation showed a risk reduction for development of high-grade dysplasia or cancer, with RFA patients developing it 1.5% versus 26.5% in those under surveillance, with a recommendation for treating Barrett's with low-grade dysplasia with RFA because of this risk reduction. The median follow-up was 73 months, and the absolute risk reduction for cancer was 32%. But notably, in the surveillance group, 50 of the 68 patients, or 74%, did not progress, which begs the question, can we better refine the selection of criteria for endoscopic eradication therapy even further? Risk stratification improves selection for endoscopic therapy, particularly in patients with Barrett's with indefinite for dysplasia or low-grade dysplasia, where we know that pathology has a significant inter-observer variability for interpretation. We can use clinical demographic factors and biomarkers to decide if patients just need close surveillance, endoscopic therapy, or routine surveillance. For example, the diagnosis of prevalent neoplasia can be made in H&E stains of slides from the Barrett's esophagus. However, when there is active inflammation, as shown in this slide here, where there is in fact an ulcer and potentially reactive changes, the p53 immunostaining can show weak wild-type staining, therefore supporting the idea that this is not true dysplasia. In contrast, when there is potential dysplasia based on the hyperchromasia and the nuclear abnormalities shown in this slide, the p53 aberrant strong immunostaining shown in this image can support the diagnosis of true dysplasia. What about predictors of future progression? We currently use clinical or demographic factors such as male gender, long Barrett's, and smoking, but also we use the presence of low-grade dysplasia and high-grade dysplasia in biopsy specimens. P53 immunostaining, as I showed you, can also be helpful when it's strong, as shown in the slide before. However, molecular markers, including aneuploidy, somatic mutations, and epigenetic changes, can also be helpful. For example, in this nice study from the Rebecca Fitzgerald group with the Mayo Clinic, Barrett's length clearly correlated with prevalent neoplasia or incident neoplasia. In this study from the Cleveland Clinic Foundation, factors associated with progression included low-grade dysplasia, male gender, multifocality, presence of nodules, and Barrett's length. On the other hand, presence of indefinite forehead dysplasia, older age, and shorter Barrett's esophagus were associated with regression of dysplastic changes. P53 immunostaining has been proven in large case control and prospective studies to be able to separate progressors versus non-progressors. Most importantly, even if the sensitivity for prediction is 64%, the negative predictive value is 95%, which suggests that when positive, this is a strong biomarker for prevalent dysplasia, which can potentially influence our decision making. The limitations of P53 immunostaining, however, include inter-observer variability in interpretation. In this important long-term study from Cambridge with Dr. Massimo Di Pietro and Rebecca Fitzgerald, patients were tested at baseline for 9 biomarkers, which involved gene regulation, epigenetic changes, and chromosomal changes, particularly P53 immunohistochemistry in formalin and fixed slides, and aneuploidy in fresh biopsies via flow cytometry. The median follow-up was 4.6 years. And as you can see from this chart, 42 patients progressed from non-dysplastic, Barrett's esophagus, and low-grade dysplasia to low-grade dysplasia and high-grade dysplasia or cancer. Approximately 33% of the total 203 patients at baseline. P53 overexpression at baseline predicted short-term progression within 12 months, or clearly was able to predict the presence of prevalent missed dysplasia. When you combine aneuploidy with P53 immunostaining, this molecular marker model beat clinical factors such as age and Barrett's length with a ROC curve of 0.68 for prediction of any progression. Aneuploidy is also an important molecular marker to predict Barrett's progression from no dysplasia to high-grade dysplasia or cancer. In this prospective multicenter cohort study, aneuploidy showed a 6.6-fold increased risk if positive. The limitations of aneuploidy, however, are that the sensitivity is low, but the positive test is more important and more actionable for potentially suggesting endoscopic ablative therapy in patients with Barrett's with no dysplasia. The limitation also is that fresh biopsies are needed for flow cytometry, which is not widely available. Also, tissue sampling is critical to detect aneuploidy in the Barrett segment, and therefore targeted biopsies with digital chromoendoscopy, autofluorescence, or brushings in addition to Seattle biopsy protocol are important to improve the sensitivity. Another potential commercially available test that uses mutational load, or the Barrett is important to know. These can be derived from microdissected specimens with worrisome features for neoplasia. In this case control study from UNC, you can see here that the progressors had a much higher mutational load than non-progressors, and the overall accuracy with a mutational load of greater than 1 and a prediction risk of 0.95 was quite interesting. A commercially available pathology assay called TissueCypher uses immunofluorescence to label 9 biomarkers which are associated with epithelial and stromal changes, as well as nuclear abnormalities in formalin-fixed biopsies. Therefore, using these biomarkers, one can then stain for immunofluorescence and then calculate a fluorescence intensity score to create this TissueCypher risk profile, which integrates 15 features to produce a risk score from 0 to 10 and risk class of low, intermediate, or high. This risk score predicts the presence of high-grade dysplasia or cancer in current times or in current samples, as well as a 5-year progression probability. For example, in a risk score of 7.8, which is high, the 5-year probability of progression is shown here, which can potentially predict the presence of high-grade dysplasia or cancer within 5 years. TissueCypher also predicts progression from non-dysplastic Barrett's esophagus. For example, in this 76 patient study that compared 36 incident progressors from 38 non-progressors from the Rebus registry, TissueCypher predicted incident progression from no dysplasia to high-grade or cancer, but increased the sensitivity from previous studies to 69% by including tissue from multiple levels without affecting the very high specificity. In a 5th validation study, 155 patients, including 34 progressors and 121 non-progressors, in the screening cohort for the SURF trial of RFA versus surveillance conducted in the Netherlands, TissueCypher predicted incident progression as well as prevalent high-grade dysplasia or cancer in patients with community-based low-grade dysplasia. All in all, a total of 882 unique patients, including 231 progressors and 651 non-progressors, have been studied in TissueCypher and its role for predicting current dysplasia and incident dysplasia. The potential impact and clinical utility of TissueCypher on decision-making was illustrated in this recently published study from David Deal at Geisinger Medical Center in 60 Barrett's patients with no dysplasia, indefinite for dysplasia, or low-grade dysplasia. The management plan was impacted in 55%, which included upstaging the risk in 22%, leading to the decision to perform endoscopic therapy or at least closer surveillance, and to downstage the risk in 33%, leading to recommendation for routine surveillance. The potential cost-effectiveness of TissueCypher in our clinical practice was illustrated by this paper, which used Markov decision modeling to compare the cost and quality of life from the U.S. health insurer perspective using the Geisinger Medical Care Integrated System data. The incremental cost-effectiveness ratio was 52,483 per quality of life years, which showed that TissueCypher could potentially be cost-effective when used to downstage low-risk patients and upstage high-risk patients. In conclusion, risk stratification can help us distinguish progressors from non-progressors, select high-risk patients for endoscopic therapy, and lengthen surveillance for low-risk Barrett's and minimize overtreatment. Dysplasia grade by pathology slides and expert pathology is still the most valuable predictor, but biomarkers can help identify high-risk patients who are ready for potentially endoscopic therapy versus continued surveillance. TissueCypher in particular is ready for prime time. Thank you for your attention.